Hi, everybody. Why don't we get started here? And thank you for coming. Hope everyone enjoyed the croissants and fruit. There's plenty out there, so grab more if you're still hungry. And I think we all know Peter Karachunski, and he's going to talk about past, current, and future in the management of muscular dystrophies, Duchenne muscular dystrophy as a paradigm. So, Peter, thank you.
Good morning. So, thank you for coming early morning, and I'm happy to here to present this talk. And I've been around for a while. So I was trained here in this department, and I went through residency and fellowship in clinical neurophysiology and neuromuscular medicine, and so my focus is neuromuscular disorder. Of course, Duchenne muscular dystrophy being the most common condition is one of the main focus that I have. So today I want to talk more in general terms about this, as I've never had an opportunity to talk about this topic in front of this auditorium. So I'd like to give more general information, and mainly with focus what current care is for these patients and what the future holds for us. So I'll start with disclosure. And so advisory boards for Sarepta, Biomarin, and Bamboo Therapeutics, all the companies involved in muscular dystrophy research. So objective of today's talk is to one, define diagnostic approach in muscular dystrophies, describe multidisciplinary approach in treatment, and discuss emerging therapeutic approaches. So first, I want to kind of define what muscular dystrophies are, and it is a heterogeneous group. It's not disease, it's many. A heterogeneous group of more than 50 genetic disorders caused by mutation in more than 100 genes. It manifests with progressive muscle weakness that leads to loss of vital functions such as ambulation, bulbar function, swollen, speech, and respiratory involvement, also heart involvement. And it's usually caused by gene defects, results in abnormal production or a function of a muscle protein that leads to destruction of the muscle or loss of function. So here's that's the normal muscle. So just to see what we, when we do muscle biopsy, that what we see when we encounter a patient with a muscular dystrophy, and we see quite significant change comparing to normal muscle. Disorganized muscle tissue, a lot of fibrosis, big and small fibers, some necrotic fibers, inflammation, so many changes taking place. So the discovery of muscular dystrophy began in 19th century, and actually from discovery, Duchenne muscular dystrophy. And then it went on to 20th centuries, and when scientists realized and neurologists realized that there are different types of muscular dystrophies, and we'll talk a little bit more about this. And then the later period is 20th and 21st centuries, where the advancement in molecular biology allowed us to even better understand and define muscular dystrophies. So there are major forms of muscular dystrophies, but these are more category of the diseases than just a few. So it's myotonic dystrophy, dystrophinopathy that we're going to talk today mostly about, limb girdle muscular dystrophy, facioscapular humeral muscular dystrophy, congenital or oculopharyngeal, distal myopathy, Emery Dreifuss. All of them have different flavors and patterns. And so basically, our initial approach in those conditions is to identify the pattern of muscle involvement and progression. And so that's the first that we kind of look at, and whether it's generalized muscle involvement, that's what we mostly see in congenital muscular dystrophy with some flavors. Duchenne muscular dystrophy, Becker muscular dystrophy, and limb girdle muscular dystrophy, distribution of the muscle involvement in girdle muscles primarily. And then Emery Dreifuss muscular dystrophy that has a different peculiar pattern of presentation with shoulder involvement and distal anterior leg involvement with some contracture development. Another example is facioscapular humeral muscular dystrophy that present with facial involvement and truncal muscle involvement and shoulder involvement. Distal myopathy, so mostly involvement in distal muscle, upper and lower extremities. And then myotonic dystrophy also has a different pattern of presentation and some other features that are important to pay attention to. Now, in addition to that, so that's initial impression, but then once we understand the pattern, if we're able to, then we try to classify it based on the specific gene involvement and protein. And this is slide not to go into details, but just to give you a general sense about how complex this system is. And if you can look at this cartoon, so this is representing sarcolemma, the muscle cell membrane, this nucleus, this contractile apparatus, this extracellular complex that also includes a lot of proteins. And this is protein dystrophin that links sarcolemma with contractile apparatus via actin, binding to actin. So any of these proteins listed here, genes listed here, can cause a muscle condition. So, and based on the patterns I just described above, we can guess from these patterns which group of disorders we need to target. Limb girdle muscular dystrophy, dystrophinopathy, Emery Dreifuss, and some other forms of muscular dystrophies. So that's just a brief list of different conditions that we can identify. Well, it's not complete. So now you kind of have a general perspective on this, and so now I'm going to focus on dystrophinopathies. Well, because it's the most common and most deadly condition among the all, and it was, of course, first recognized, and we know most about this comparing to others. So, and that includes Duchenne and Becker muscular dystrophy, manifesting carrier, and X-linked isolated cardiomyopathy. So there are different flavors caused by the same gene. So a little bit of history. So its name is given after Duchenne, Dr. Duchenne, who was a French neurologist, and who was the first. He wasn't the first who recognized this patient, but he was the first who actually gave a really good description and his drawings are famous of muscular dystrophy. He labeled pseudo-hypertrophic muscular paralysis and wrote a paper in 1868. He recognized that it was a primary muscle disease, primarily because he was first who developed the technique for muscle biopsy done in live people. So then followed by also a name we use frequently, Dr. Gowers, who has described a large cohort of patients, 81, which is a lot for that time, and give description of this maneuver that these patients use, and you'll see an example in one of our patients. And then there was a major gap of nothing happening in terms of muscular dystrophy. Of course, there are many other issues related to health that around that time were more important probably, as it's quite rare condition. But then, starting in 70s and 80s, there is a significant interest and effort in understanding of this condition. So in 1987, dystrophin gene was cloned, and that sparked huge interest and effort. And then in 2001, that's not a major milestone, it's not related to research per se, but there is a MD Care Act was passed in the Senate that was spearheaded by Paul Wellstone, senator from Minnesota, and that it's allowed to allocate specific funds to create centers of excellence that would provide research and clinical efforts in this condition. Around the same time, Paul and Shelley Wellstone Muscular Dystrophy Center was organized here by John Day and Laura Ranum, and so which is still in place and striving. So what is Duchenne muscular dystrophy? So Duchenne muscular dystrophy is due to mutation in dystrophin gene, that is largest gene in the genome, and it's located in chromosome X. The birth prevalence is 1 in 5,000 and of boys, and it is a fatal disorder with predictive course. It's usually diagnosed at the age of 3 to 5 years, with some exceptions, and it has a rapid progressions after 7th birthday, and it's loss of ambulation around 10 to 14 years of age, and early deaths from respiratory failure and cardiomyopathy in late second, third decades of life. So that's what we see when we get a muscle in more or less advanced stage of this disease, and you can see that's an entire muscle section, and you can see how disorganized this tissue is. You see a lot of pink stuff and white stuff. This is fat deposition. This is connective tissue. So fibrosis of fat is remarkable in this disorder. And then you see muscle fibers that are all different sizes and shapes, and some inflammatory cells around. So if we do staining of the protein, which we can do with antibodies, we see this green staining in wild type and normal individuals. That's a staining of dystrophin. And in Becker muscular dystrophy, which is milder form, I'll talk a little bit more about this. You see just a little bit, and essentially nothing in Duchenne muscular dystrophy patients. That can be visualized by doing and measured by doing Western blot. And so you can see full-length dystrophin, liken it in Duchenne muscular dystrophy, and have a shorter version, truncated dystrophin, with assumption that it is functional in Becker muscular dystrophy. So diagnosis based, again, we talked about pattern recognition. So if you see a young boy who has these symptoms, gross motor or global delay, weakness and abnormal gait, typically weakness and abnormal weakness is a late, it's not a late symptom, but it's understood as weakness later, because typically this boys present with delays, and one of the recent publications on very young children, infants with Duchenne muscular dystrophy, showed that these boys are not doing the same as other children. Therefore, it's important to check CK level in any young boy who presents with gross motor delay or delay in general. And then it's followed by genetic testing. And so if CK is high, so I'll talk a little bit more about this, then we do genetic test. Muscle biopsy essentially is not necessary right now for the most part, with a rare exception when the genetics is controversial. And CK level is what you need to suspect this diagnosis. It's happens in all boys with Duchenne muscular dystrophy, and it's quite significant. It's not 1,000. It's going to be so. Even in infants, there are some studies that are done to look for possibility of newborn screen, and the CK was used as a screening. So the elevation of CK was at least 2,000. So anyone less than 2,000 is not even a concern, especially in older boys, and which is almost true for Becker muscular dystrophy. Now, in female carriers, that's not 100%, and so we can't rely to make a diagnosis of carrier status on CK levels. So here's the algorithm that is suggested for diagnosis. So if there's no family history and we have a young boy with gross motor delay and muscle weakness, check CK. Any child with family history of DMD and concern for motor difficulties, also we check CK and screen for muscular dystrophy. And later, anyone who has unexplained isolated transaminases should be checked CK levels before doing liver biopsy. We have many examples of liver biopsy in patients who have muscular dystrophy. So, and then once CK is found to be elevated, we suggest to refer to Midday Clinic as it is most likely to be genetic, and we would probably do this first. Again, we look at the pattern of clinical presentation, so we'll do the genetic analysis first for deletion duplication and gene sequencing. And muscle biopsy remains an option, but not always done because we have many other genetic tests that we can do before muscle biopsy. And once the diagnosis is established, a patient should be referred to MD multidisciplinary clinic. So here's the example, one of patients who presents with significant muscle hypertrophy. Not only calf muscles are enlarged, but other muscles too. That's why he's sticking the tongue out. So the tongue is big, and so and we look for patterns of weakness, and hopefully it's going to work. Well, I checked it earlier, so I should have checked it. Well, I guess we're going to skip that and then the Waddlin Gate. So most of you probably know this and can imagine how it looks like. But that's what we look for. Just don't forget to, when we see patients, especially for a neurological problem, to look for function that is getting up from the floor, taking stairs, walking, and so forth. So here you see another example of two boys, two brothers, and so just to emphasize the progressive course, which can be seen comparing posture of these two brothers. They are still young and doing fairly well, but you can imagine a little bit more hyperlordosis and change in posture in the older boy. There are some other techniques that can be used to track the progressions, such as muscle ultrasound, and we can see the difference in these two boys based on their function. I'll talk a little bit more about 6-minute walk test that we do for these patients. But in this test, the boy in the middle panel walks longer, 379 meters as compared to this boy, and you can see the difference in echogenicity of these muscles. So white is worse. So how we look at the progression and phases. The first phase is 0 to 2 years. First it was called pre-symptomatic. I think it's a misnomer given that many of these patients can have delays. But it's not appreciated as muscle weakness yet, and these patients continue to show improvement and acquiring milestones. Then the next stage in toddlers is early ambulatory stage, when we see still improvement in motor function, but it's delayed compared to their peers, and you start to appreciate change in gait, such as toe walk and hyperlordosis, Waddlin Gait, and mild Gauss sign. And then at that point, patients reach plateau and gradually progress to late ambulatory phase, when the gait is labored, they cannot run, jump, they cannot take stairs, and they develop significant contractures. And then early non-ambulatory stage, when they start using wheelchair most of the time and have fairly decent function in the upper extremities, followed by the late non-ambulatory stage in mid to late teens that with significant impairment in upper extremity function. They have more respiratory difficulties and more likely to have cardiomyopathy. So while it's kind of intuitive that that's the case, recognition of this is important, and because there are many clinical studies, then it's important to recognize these findings and also use them as outcome measures. And how do we measure progression? So we use time tests, and one of the most early time tests that were in use in this patient population is stand from supine, stair climb, and sorry, that was a duplicate. It's actually 10 meters walk, not stair climb, the lower graph. And so this particular study, which we were part of, it's a multi-center study done by the Synergy Network that looked at the time test, and they found that boys who are older progress much faster, and this time point turned out to be around 7 years of age. So, and you can see that the upper, I'm not seeing the, anyone seen? Just going to use there. So so the upper line is the older boys, and they progress faster, so that it takes longer time for them to stand up. As opposed to boys who are younger than 7, they actually change very little over the course of this time of observation, which is 48 weeks. Why 48 weeks? Well, it's the most common time for the clinical trial. So, and that's an important information. And actually, it holds true for many of the measurements, stair climb and 10-minute walk. So you can see it takes longer time for them to walk 10 meters and stair climb. The next measurement, which is commonly used now, is a 6-minute walk test, or we measure distance. And here again we see here's the split is a little bit different. So what they looked at the function, and so what they found that the boys who are walking longer than 350 meters progress very little over the course of 48 weeks, as opposed to boys who are less 350. So again, this is an important finding when it comes to selecting patients for a clinical trial, which is usually short in duration comparing to the course of this disease. That's one of the challenges. And so now let me talk a little bit about Becker muscular dystrophy, because understanding of this led to many developments in this field. And first, I want to mention that it was discovered way later than Duchenne muscular dystrophy, essentially 100 years later. It was understood that it's very similar to Duchenne muscular dystrophy, and due to presence of dystrophin, not complete lack of function, but presence and also presence of function. And then that symptoms appear later and they're milder and progress slowly. They have less issues related to respiratory involvement and spine deformity or secondary changes, but they have cardiac involvement that does not always correlate with the skeletal muscle function. And then survival usually is to older age, and a much greater variability. There are patients who could start using wheelchair in the third decade of life, and there are some patients who are still ambulatory in the sixth decade of life. So the variability is humongous, and heart disease is important in this condition. Now, Becker muscular dystrophy, as I mentioned, due to, again, mutation in dystrophin gene, but as opposed to normal gene, it has a shorter version that make this phenotype milder than Duchenne muscular dystrophy. So, genetics of this disorder is understood fairly well, and now we know many different mutations and variations. And here's the types of mutations that we recognize. The most common are large changes, such as deletion or duplication. And so they encompass close to 80% of all cases. And then there are some other types of mutation: nonsense insertion, deletion, missense, intronic mutations. And they're found both in Duchenne muscular dystrophy and Becker muscular dystrophy. It's found all over the world, and with greater population, understandably recognized and characterized in Europe and North America. So understanding genetics turned out to be fairly important. So the difference, I'll talk a little bit more about this later, but that understanding led to development of novel treatments. So a little bit of pathogenesis. Dystrophin is present in normal individuals from fetal life, and loss of function in dystrophin results in lack of dystrophin protein in DMD boys and malfunctional protein in Becker muscular dystrophy. The primary function of dystrophin is to stabilize the plasma membrane, but also it serves as a signal molecule, which is understood much later. So it serves as a shock absorber for the muscle membrane to sustain mechanical contraction. And so there are some other mechanisms are recognized, and there are many of them to talk about. It's not the focus of this talk. And dystrophin is very specialized for skeletal muscle, but there are other isoforms that are present in other tissues, including the brain. And so that potentially can explain why we see other involvement rather than just in muscles, skeletal muscles. So here's the picture, and it's this was published in 1974 by Dr. Engel from Mayo Clinic, and so he showed actually that you can see these gaps and destructions in the cell membrane that is caused by lack of dystrophin and probably from ongoing injury to the muscle, which happens in normal condition and when there is no dystrophin. And so it leads to fragile sarcolemma, increased calcium influx, activation of enzyme, membrane lesion in addition to that, and muscle degeneration. And there is a great attempt to regenerate, and the muscle has the great capacity to regenerate, but it's just not able to keep up. So over time, you see development of connective tissue fat deposition, what we call fibrosis, and replacement of normal muscle by abnormal tissue. So we look at the muscular dystrophy as a multisystemic disorder. It's important to recognize because it defines the care we give these patients. And so we talked about motor decline, but there is also significant pulmonary involvement, cardiomyopathy, a major element, endocrinopathies are common. Some of them related to treatments we're doing. Cognitive and behavioral dysfunction can be very significant and is a huge spectrum. Orthopedic complications, sleep dysfunction, gastrointestinal dysfunction, and bladder dysfunction. So obviously, no one can do it all, so that's why the consensus is that the approach has to be multidisciplinary with the family and patient-centered approach when we have many aspects addressed by different specialists. So I don't need to go over this slide, but I just want to illustrate the importance of recognizing issues related to this condition and anticipate that they may come up as the condition progresses. So here we have clinics both on pediatric and adult, and those clinics are located here now on our Discovery Clinic here on this campus, and clinics on the new ambulatory center on the other side of the river. And so we have a clinic that includes the adult clinics for muscular dystrophy patients, neuromuscular patients in general, and also Charcot-Marie-Tooth Clinic, specialized clinic, and Maple Grove Clinic, and here in Children's. And so in here we see the list of specialties that are involved in clinics, and many of them are present during the clinic visit, so they are coordinated clinics. So this slide is just to say that knowing the natural history, knowing what can happen and when it can happen, helps us to organize our clinics better and coordinate care to make sure that we provide more of preventive care for this patient in anticipation of the issues that can come up. And so there are different issues at the first stage as compared to the last stage of the diseases, and it relates to all aspects in orthopedic management, pulmonary management, and psychosocial management and others. So I'll go into a little bit specifics in this, but because any of this can be a separate talk. So, and that's the reason, doing this aggressive care comparing to what it was done before, when no specific treatment was given to these patients. So what we're seeing actually the change in natural history, and that's actually is significant, even it may seem not too much, 2 to 3 years on average, but that probably is what is resulting in delay in treatment of scoliosis, or some patients don't need to have a surgery on their spines. It's increased survival to greater than half of the patients survive behind the 25th birthday nowadays, compared to when it was before the age when we started to use treatment for these patients. More men go to college, and overall improved quality of life. I think it's also important to recognize that we need to keep this patient as healthy as possible for the upcoming emerging new therapeutic approaches that many. So we'll talk a little bit about those as well. So management. So the I showed you muscle biopsy, and when it was a gold standard for diagnosis of muscular dystrophy, what was one of the first observations is that there is a lot of inflammation in the muscle, and so the idea was that what if we treat inflammation? And of course, corticosteroids started to be very common around that time, and so Dr. Druckmann in 1974 started. He had a pilot study on patients with Duchenne muscular dystrophy. Sure enough, he found a benefit. Later on, there are multiple clinical trials, and still there are some trials related to use of corticosteroids in this patient population, which is proven to be effective. It does prolong ambulation by 2 years. You typically see benefit fairly soon, and within several weeks. Sometimes it can be fairly dramatic, but then the benefit is kind of levels off. And it's also reduced the development of secondary complications such as scoliosis, delays respiratory failure, and delays development of cardiomyopathy. But of course, we're talking about starting very young children on chronic corticosteroids. It's not without side effects, and so the common side effects are weight gain, bone health, growth retardation, delayed puberty. Behavioral complications are actually very common in early phase, sometimes can be significant. But also there are some issues related to how to use steroids, how we can minimize steroids. What if we use only weekend dosing, which has been shown to be as effective as daily steroids, or we can use 10 days on and 10 days off. So there is a lot of still controversy what the regimen is the best in terms of efficacy and side effects. There are also two types of steroids, prednisone and deflazacort. And prednisone is available in the United States, deflazacort is not. And it's available in Europe and Canada and other countries. But many patients choose to use deflazacort with the assumption, and there are some data that may be supportive of less side effects. Some of the adamant about that. That's strong argument. And the other issue is when is the right time to start corticosteroids, and we don't know yet. So right now the consensus, at least when the boys reach plateau, they need to be started. But there's more and more experts in this field think that starting early at around age 2 or even before may be of benefit. There is an ongoing clinical trial to look for this, to answer this question. Dose modification and adjustments also unanswered questions, and what to do when ambulation is lost. Do we stop steroids or will it continue? We talked about that it may be beneficial for delaying respiratory difficulty or cardiomyopathy. What I know in my experience that when we stop, many patients choose to stop steroids when they lose ambulation, but in my experience, many of them would find that they have less function in upper extremities. So, and then there's supportive and palliative care, so which includes physical therapy, respiratory care, symptomatic treatment, monitoring, and treatment of heart failure, management of GI issues, neurodevelopmental issues, and orthopedic complications. I'm going to mention about cardiac care. In many onset of cardiomyopathy around 14-15 years, but some patient can develop it early, so that's why we do echocardiogram and baseline echo when we make a diagnosis when it's a very young child, and then we monitor them on a regular basis, and annually after 8-10 years. And they also can have conduction disorders, and treatment of cardiomyopathy consists of after load reduction. Now, there are some studies that compared patients who started on AC inhibitors before onset of or diagnosis of cardiomyopathy, and they found that the mortality was reduced, at least within the time frame. That the mortality was later for the patients who were on AC inhibitors. And so now there's a trend, but no great proof to start patients on AC inhibitors before onset of cardiomyopathy. Pulmonary care is important. We start worrying about this mostly in late ambulatory phase and non-ambulatory phase, and that's where we get more aggressive about looking for signs of respiratory failure using sleep study, monitoring O2, CO2, and use non-invasive methods to prevent complications such as cough assist, breath tach and vibration, percussion, non-invasive ventilation. We know that once it gets down to 1 liter, the 5-year survival, of course if you don't do invasive ventilation, is about 8%. Orthopedic care is important, especially to monitor for spine and scoliosis. It's less of an issue with corticosteroids, but it's still a significant part. And there are some parameters we use to how aggressive to be about monitoring. Contracture management is important. Many patients, especially younger patients who lose relatively young ambulation, is quite often have significant contractures. That's why aggressive treatment, even before they develop, is important so the patients get used to it. Nighttime splints and stretching exercise are the most important ones. Exercise, again, it's hard to exercise when you lose muscle, but we still recommend to have some activity, and usually boys would choose to be active as it allows, if their function allows. And then fatigue management, wheelchair evaluation, and assistive technologies are important parts of the care for these patients. Management of endocrinopathy turn out to be important, especially in the context of chronic use of corticosteroids, all the complications related to that, but independent of that as well. And so there's at least list of these issues that we have to deal with. If look for osteoporosis, there's no clear consensus on how to approach that. Bone fractures are very common complications, are quite common. That leads to loss of ambulation or associated with loss of ambulation. When they fracture lower extremity, they go to wheelchair temporarily. They quite often don't come back to their previous baseline. And so the recent observation of low alkaline phosphatase level in these patients is sparked interest of Dr. Patrick, who is now doing a study where we're looking at, first of all, the degree of involvement and whether it can have some clinical significance. As we know, low alkaline phosphatase found in hyperphosphatasia patients who have muscle weakness. And correction of that actually improves their function. Management of CNS involvement is not a trivial issue and is for many patients lifelong. It's we talked about the spectrum of involvement, and at least on average we know that the IQ is shifted by 1 standard deviation, and there are many patients, at least 30%, whose IQ is less than 70. There are other manifestations besides low IQ. There are some patients who have significant autism, anxiety, OCD, etc. So early assessment of behavioral and cognitive involvement is important. It is also important for the entire family to provide the psychosocial support, promotion of independence, and adequate educational support. So, and we also monitor for functional outcomes, regular PT assessments, time function test I mentioned about, and currently MDA registry is based on the experience that was done in cystic fibrosis, where the creating of this registry, I understood, helped to make an assessment of care and modify care for patients with cystic fibrosis. Similar idea came for treatment of muscular dystrophy. Of course, all this is not without cost, and it's been estimated, and it's quite significant. So the annual direct cost for any given individual with Duchenne muscular dystrophy is about $55,000, and so the economy burden is here. So it's in comparison with other developed countries. So just to illustrate. And it's probably going to be increasing given that these patients are living longer and there are going to be new, more expensive treatments and so forth. So here's a little bit about therapeutic approaches, and fundamentally they are divided in two categories: the protein upregulation, whether it's dystrophin or other protein, and pharmacological approach to address other pathways that are involved. So there's a gene transfer, the use of oligomers to modify gene, and mutation suppression and dystrophin surrogate like upregulation of utrophin, cell-based therapies. So I'm obviously not going to talk about all this. I'm just going to give you one example, and that is for exon skipping, which is now is mostly discussed approach. And there are two clinical trials. One is run by Sarepta, another is run by BioMarin for this approach. And so this is based on the notion that Duchenne muscular dystrophy have the deletions that cause out of frame mutation. So which means that once the gene is deleted, there is no production of protein, in comparison to Becker muscular dystrophy, where deletion of the exon cause in-frame station, when despite the fact that you lose part of the gene, you still can produce the protein. So the idea is that if we delete more, then we restore reading frame, and so able to produce shorter version of dystrophin. So, and that approach has been an investigation, and I'll show you the next picture, which is published by Sarepta on their website. And so here you see that because this is out of frame deletion, so of exon 49 to 50, which is one of the most common mutations or hot spots for deletions. So because this can be, these two exons are not compatible, so there's no production of protein. So this approach allows to delete or skip exon 51 and restore the reading frame. Also a shorter version, but with the ability to produce protein. So, and the preliminary studies that Sarepta published for a drug they called eteplirsen showed that, so this is just a small study on 12 patients they had, initial study that showed they split them in two groups, and one group was getting drug right away, and the other group started to get drug a little bit later. And you can see the difference in progression of their condition in the group that was on placebo. So, but that wasn't a perfect study. It was not double-blind, and there are only a few patients, and therefore there is an ongoing phase 3 trial for this exon skipping, results of which we don't know. Based on this data, this company was looking for early approval, but they were denied by FDA. So there are a lot of talks about this. So we'll see what will happen. So you were involved in that study as one of the sites for this clinical trial. And then we've collaborated with other researchers, and Dr. Law from so she's a PhD, and she's a exercise physiologist, muscle physiologist, and so she studied with Susan Novotny, who was her graduate student, effect of vibration on the mouse model of dystrophinopathy, and they use high intensity vibration, low intensity, high frequency vibration. And so they came to us and suggested to do it on our patients, and we've done a small pilot study with only 5 boys. And well, first of all, we found that it probably does not cause any major decline. Here's some data. In 6-minute walk, we found that there's no significant progression over a course of 12 months. It appeared to be stable on a stair climb test over a course of vibration, but then there was decline afterwards. And so the patients first were exposed to vibration, and then they didn't have vibration, and it was true for supine to stand. We've looked at some other measurements like ankle flexion and bone density using novel technique PQCT to look for major impact. We didn't see that. And basically we showed that this approach is well tolerated, and it may have stabilization effect, but of course this is a pilot study, and it's a it needs to be proven that it can be used as a mode of exercise. That's the idea, is can we use vibration because they can't exercise otherwise. So that's one of the studies involved. So take-home message: early diagnosis of muscular dystrophy is important. Any young boy with developmental delay should have CK checked. We like to have early diagnosis for reasons that the family don't have to extended diagnostic odyssey, that the boys can have access to treatments early in the course, and maybe with new emergent treatments it's even become more important. There are more and more talks about doing a newborn screen for this condition. So a little bit about this center that we have here at the university. So clinical care is just a small part of it, but significant. There's a large group of researchers who are working on the issues related to muscular dystrophy, many of them on specifically Duchenne muscular dystrophy, education and community programs. So here's the one of the fun events we have for these patient populations is Lab Day, which is when the researcher have an opportunity to meet patients, which gives hope to patients and inspires researchers to keep going. You're also all welcome. So, and then we also participate in doing the community work, as this patient live with this condition all their life, and they need extra support, not just the medical care. So, and these are all sponsors and grant foundations. And then I want to thank you, many people who are involved in providing care, research, and education for patients and families. And so these are the names of the main key players, and I'm sure I missed some, and I apologize for that. So I think I'm done with my talk. So if you have any questions, please feel free to.
I just have 2 quick questions. First of all, the hypertrophy, is that hypertrophy of the unaffected muscle that's compensating and getting bigger, or is that the disorganized muscle? And then second, chronic steroids Are you using any of the anti-inflammatory drugs like that used in rheumatoid arthritis, or trying to avoid the steroids?
Yeah, so that was my, thank you for your comment, first of all. That was my goal, to show how complex this is. And so in terms of muscle hypertrophy, yes, there is a compensator. So there, if you look at the microscope, you see very large fibers. But we use kind of term pseudo-hypertrophy, and that's in part because there is probably enlargement of the muscle because of replacement of the tissue with fibrosis. So there is a lot of fibrosis going on. So, and I think there's both. True hypertrophy, which initially helps to compensate, but then it loses this capacity as fibrosis progresses. So now in terms of other anti-inflammatory drugs, yes, there are a lot of attempts to look for anti-inflammatory, and then why? That's why. So I know there are many common drugs were used, like methotrexate, CSA, and some other more novel drugs used to treat DMD without success. And that's one of the reason people don't think that inflammation is not the reason steroids work. Anti-inflammatory action of steroids is not probably, or not only the reason, let's put it this way, it's probably not the reason. There are many other mechanisms which we don't completely understand why steroids work, actually. There are also studies about, there's a novel drug is in development that has steroid function but without steroid side effects, presumably. So we'll see what will happen in the next few years. So that's a major. Well, or Ape, yeah.
Why did Peter and Sheila Wellstone get involved? Do they have a family member, or what was their interest in this disease?
Oh, so no, it was actually one of patients from our clinic had personal interaction with Paul Wellstone, and so he was very touched on a personal level, and he went on. So he was actually the reason this MD Care Act was passed in Senate, and so it's kind of a Minnesota thing. now.
Peter, what's the thought behind the lower IQ in boys with Duchenne muscular dystrophy? Why do they have a lower IQ?
Why? Well, as I mentioned, there are some other. The dystrophin is present in the brain, and so I don't think we know exactly why, but the assumption is that there's probably some function at play since it's there. And as I mentioned, as we recently start to understand that dystrophin also plays signaling role. I don't think, because the developmental issues in these boys and low IQ are not progressive. They don't get worse. They actually, if anything, that some boys are get better. So with some learning difficulties. So I think that's less understood problem, but there's probably biological reason for that. It's not by chance. Because we have other examples of neuromuscular conditions where cognitive function is spared or even superior.
Well, I think we need to wrap up, so thank you very much.
Thank you. Thank you.